Okay. Welcome, everybody. It seems that we've already got 85 people coming and lots of other people coming in. So it's very strange, isn't it, talking to a screen with the housekeeping on it. I'm just trying to imagine everybody coming in and getting settled. And it's hard not to imagine people coming into a hall, really, isn't it? Welcome to this session. This is a presentation by Gail Simon, and it's entitled The End of the Clinic, Reimagining and Reconfiguring Systemic Training and Practice. So we're delighted that so many people can join us here. I'm Claire Barber-Lomax. I'm here from Friends of KCC, and I'm here to support Gail today. And I'm going to ask my two colleagues who are also supporting Gail to introduce themselves. Over to you, Karen.
Hello, I'm Karen Partridge.
And you're from KCC too, aren't you? And
I am, yes.
Hi, I'm Sian Tate. I've been part of the organising committee on behalf of AFT.
And of course, we're going to welcome Gail, but I will welcome Gail properly later. Thank you so much for joining with us, Gail. So it is my great pleasure to be able to introduce you, Gail. And I want to start off by thanking you. I really want to thank you for all the contributions you've made to our profession. I think actually I could probably take the whole session talking about all the things that you've achieved, all those special interests that you've got, all the papers you've published and the books you've written. The books are available in the bookshop for anybody who's interested. But obviously nobody's come to listen to me, so I know I have to be really quite selective. The Gail I know is someone who's not constrained by existing boundaries. She might push against them or just calmly and efficiently find ways around them. She's also someone who strives to give voice to so many differing minority groups, and she passionately supports practitioners to be the very best that they can be. It's a real privilege to know her. Gail trained with KCC in the early 1990s, and then, believe it or not, she persuaded Peter Lang and Martin Little and John Schotter to finish the work that they'd started on developing their doctorate programme, because of course she was one of the first on the cohort. And so many others have benefited from her energy and persistence in ensuring it's set up. Then, later on, when KCC was no longer able to offer the doctorate programme, in true Peter Lang style, Gail just set one up. And her amazing creativity, combined with true rigour, has enabled her to drive forward very fresh ideas about systemic research and practice with great success. She's been the programme director now for the past 10 years. I'm just finding my notes here. In her spare time, of course, because I think Gail's got 36 hours in every 24, Gail is a relatively new, she's an editor of a relatively new journal called Murmurations, the Journal of Transformative Systemic Practice. And if you don't know it, it really is worth a read. Do have a look. It's on this perfect address, murmurations.cloud, and it's all online and it's free. And on top of that, if you're considering submitting a paper, don't worry if you don't feel that confident about your academic abilities, because that's okay. In Gail's usual style, she offers 2 workshops a year on writing for publication. So Gail seems to thrive on innovation, and 30 years ago, embracing diversity from the outset, she set up a practice for lesbian, gay, bi, transsexual, queer and intersex people and their families. And the Pink practice thrives today as both a national and an international service, and is Gail's therapeutic home. I know it holds a very special place in her heart. I'm so looking forward to hearing Gail's ideas about reimagining and reconfiguring systemic training and practice. I suspect we're in for a really interesting session, which will expand all of our horizons. And thank you, Gail. Over to you.
Gosh, Claire, what a lovely introduction. Thank you. Thank you many times. And I was thinking, the very first question in my doctoral viva that Sheila McNamee asked me was, how are you building on the work of others? And I felt, funnily enough, really anxious about answering that, because I didn't want to be so arrogant as to think I was developing the work of others. You know, these theorists are our heroes. These contributors are people that maybe I need to feel are just there, their work unquestioned. And yet, of course, that's our job, to critique, think about relevance and theories in context. And so I say that because it's, I think, for example, the professional doctorate in systemic practice was very much a development out of KCC. My ideas are not my ideas. Mikhail Bakhtin would have perhaps, that overused quote that I don't remember, saying the word in itself is half someone else's until we populate it with our own meaning. But even then, maybe in the systemic field, we wouldn't talk about our own meaning. We'd be thinking more about co-creation and the we and the us and the we and what we're making together. Anyway, I can't remember how I got onto that, but thank you, Claire, for that introduction. Thank you, the Friends of KCC, for this invitation. Thank you, AFT, and thank you, CMM Institute, for your part in this invitation. Much appreciated. Bit scary, always talking with one's community. And of course, not being able to see one's community. I'm not sure what's worse, whether it's not being able to see people or seeing lots and lots of faces on the screen, but I know you're there. And a couple of people have sent messages saying I'm waving, which is very sweet. And thank you. I like being waved at, even if I can't see the waves. I'm waving back. And I'm also looking forward to the feedback and responses, because I suppose following on from this idea that the word in itself isn't just ours, and that it is a wave, that it is part of its ripples. I've always thought of papers and presentations and communications of any sort as being kind of like pebbles in a dialogical pond, where we're interested in what comes back. That's how we think, isn't it, as systemic practitioners? So these ideas today are the result of all kinds of heard and found and random and thought through responses and ideas from other people, from within and outside of the systemic field. I'm going to show you some slides. And they start with some history of the clinic, briefly, in pictures, in thoughts and responses. You'll have your own reactions. Some of my problems, some of our problems, whoever our is, you can decide, with the concept of clinic and how systemic people have found themselves in clinics. And invented other fora in which we feel we can work. We're going to go on to think about how to decolonize the setups, linguistic, material, practical, political, in which we work and train, how we can depathologize the discourses and therefore the practices and the legalities of what we're apparently allowed to do or not do. And we're going to end by thinking about space, the politics of space and the poetics of space, by looking at some pictures. So you'll be relieved to hear that the last 10 or so slides are pictures just to look at. Anyway, I'm now going to share my PowerPoint with you and hope that Claire, would you give me a thumbs up if you can see that? And it looks all right?
Indeed, yes.
Good. Okay, I'll say more about this picture in a moment, in a few slides' time. These are some of my homes, my moving homes, the Pink Practice, University of Bedfordshire, where I program leader for the professional doctorate in systemic practice, which Peter, Martin, and John set up in 2006. Thank you, Claire, for mentioning Murmurations, Journal of Transformative Systemic Practice. And there'll be mention of a new venture, Lenticular Futures, towards the end of the time. Oh, first, I should have given you a warning. Oh, the history of our profession is not always pretty. And when I say our profession, I mean the psycho, well, our roots. And when I say our, that's a bit tricky, because you could say our roots as systemic practitioners belong in group therapy or family therapy and so on. But the clinic is partly what we have in common with with our colleagues and the discourses. So I was searching around like you do. I thought this was a difficult picture. The first photo of a psychiatric patient in a journal, des hôpitaux, contracture hystérique, hysterical contractions. Oh my God. So I think looking at these pictures is really tricky, because one's immediately in a gaze position, looking at the frame around the person, separates the viewer from the experience, or does it connect them? People would say maybe it's a picture, depending on the context, that can generate empathy. I don't know. But I think the point is the context in which this picture was taken, possibly, probably, was taken in order to demonstrate something to a scientific audience. And therefore, the person in the picture is othered. They are a specimen with symptoms, very interesting symptoms. And I've noticed recently how the word interesting isn't sitting so comfortably with me when, yeah, I'm mixed in feelings about it. This is another early picture of people in a psychiatric hospital. Of course, it's hard to tell what people might have been feeling, what kind of reassurance or comfort or discomfort or fear they may have been feeling. The dog looks relaxed. Well, we don't know what the dog's job was, to comfort or guard or who knows what. But I mean, this is, in a funny way, something that hasn't changed either, in as much as we don't always know what other people are feeling when they come to see us in a clinic, because everybody's performing. We're trying to do the right thing, make a relationship, be welcoming, extend our hospitality, put people at their ease. But we know people talk in very different ways when we're on the bus with them, in times when we were on buses with people, and when we're in other contexts. So this is a problem. What can we ever know? These are sort of historical pictures. Der Institut für Sexualwissenschaft, Hirschfeld's laboratory into exploring, investigating, interrogating, what are the right words? People's biological sex. This is kind of a provocative picture, because for me, because you know, my people in the lesbian, gay, queer, bi, trans communities, intersex communities, have been scrutinized for all manner of strange relationship with knowledge. People as curiosities, people as, half a step away from putting a specimen of a brain in formaldehyde and studying it. Very scary equipment. And of course, half a step away from Mengeler's experiments on people and well, we'll come back to that in the next, one of the next slides, but this is interesting. Oh, there's that word again. It's a separating word. It's a separating word. It's a safeguarding word. It allows one perhaps sometimes, or me anyway, I should speak for myself, to be interested in stuff, to be engaged in material, and maybe create a little bit of distance so something isn't quite so difficult as I'm probably experiencing it as being. Psychiatry under the shadow of white supremacy. This question posed in a paper from the book that is cited here. How does a culture that enslaved people, encouraged lynching, developed racial segregation, decide who is and who is not sane? And of course, we know that people of color, Black people, are overrepresented in the psychiatric system and the punitive system. And here we have Hans Asperger. I look at his face and I wonder what he was like. I'm sure he was a good sort, probably a nice man. How does one square these things? So maybe he was a caring and attentive physician, and yet he passed on his recommendations of his assessments about whose lives would be socially productive or not to the Nazis, so that many of his patients were rounded up and executed. A difficult inheritance for those carrying diagnoses that may once have been a relief, called Asperger syndrome. And of course, our systemic profession isn't exempt. This is a difficult one for me. Hill End Adolescent Unit in the 1980s performed some very cruel treatments on the young residents there by a leading family therapist, a very well-known family therapist. Lots of us people who were around during that time will know about this. There's a big movement, a big investigation that's been ongoing for a long time into the abuses there. So the ideology of the clinic, those are some of the, for me, the more difficult photos, but I think it's important to look at some of the backdrop to what we now call clinics. They're medical constructs intended originally as a place to take specimens, to isolate disease, to identify disease and treat it, a place in which there would have originally been medical power. In our context, it's often psychiatric power in terms of who has most clinical responsibility or clinical authority. And the idea was to not only reveal the truth of an illness, but for the physician to be the producer of that truth. That's a very interesting positioning. So we've got the discursive and the embodied practitioner through whom the truth can be brought forth, found. And the idea, as Foucault was talking about, is to take people out of their milieu to avoid what Foucault termed as the parasitic vegetation feeding off the problem. But interestingly, Foucault pointed out that in a post-Pasteurian Louis Pasteur world, the physician moving from bed to treat patients or assess them also became the means of contagion. And I think this is a very interesting problem for us, because we're also involved in, let's call it, practices of discursive contagion, where the more we, I don't know who's involved in that, you can decide, the more the mental health professions talk about or the discourse of mental health is promoted, the more contagious or growthful or spreading it seems to be. Certainly the clinic's a message about the location of expertise to separate people from local knowledge so that the knowledge gets embodied, the expertise in the professional, and much as we've all absorbed and appreciated the writings of Harleen Anderson and Harold Galician about the location of expertise and deconstructing expertise. The truth is, we're working in systems that decide what the referral criteria are, what the gateways are shaped as to who gets through them or not, and who gets how many and how long they have to wait and what counts as urgent and all the rest. So the expertise and power are very closely linked, because we're using expertise in order to inform the power and vice versa. Clinics are also therefore a show of power. They're a demonstration of power, and in some ways social control. You know, it wasn't that long ago that homosexuality got taken out of, that word homosexuality, strange term, an othering term, got taken out of the DSM. And hopefully autism in some of its forms at least will be taken out of the next DSM. But there's something about the anatomical atlas of the body and the head. If you think of those, I should have put a picture up of them, those strange segmented porcelain things that create geographies apparently of the brain, of the mind, and so on. They parallel also geographies for us of the modern clinic, the who's who. We are also mapped into the geography of the clinic. And in some ways, the kind of paramedics of those who hold the main power. This is, I was looking at buildings. I can't remember how I came across this picture. This is a house a colonial building in Jamaica that was part of the Port Authority in Port Royal that was dislodged during an earthquake. But for me, it speaks to a metaphor for the clinic now, that it's a colonial relic, that it's not fit for purpose as it's set up, as it stands, or as it sinks. So the unsustainability of the clinic for me, and is that there's a pathological focus on pathology, if one wants to join in the language in a sort of ironic way for a moment, that there's over-attachment to certain theories and to certain power structures, theories that haven't been interrogated for their ideological influence. What's behind them? They were made at a certain point in time. I'll say more about that in a moment. There's an imbalance of power relations in service delivery, in access, in design, in staffing, in recruitment. There's a very hard to shift ideology in the clinics. And I think this is a particular problem for us as systemic practitioners, where we are trying to be good people, open people, dialogical listeners, ethical respondents, nice, paced, doing good conversation with people. And often that means listening first. We're not terribly pushy. We might be in certain situations. Again, this problematic we, so forgive my generalizations. I'm trying to, I suppose, draw attention to some ways of talking and being in relation that where maybe we haven't understood how to speak translinguistically. I've spoken about this before. Systemic humility is a real problem when trying to talk across paradigms. So what does that mean for us when we try to help people de-isolate the individual, see problems in context, see them in a range of contexts? But we are also isolated sometimes as sole systemic practitioners in a clinic, in a minority, not having much time to talk either with other systemic people, with colleagues, or with colleagues from other, who are subscribed to other discourses and paradigms and ways of understanding the concept of problem. We're probably also part of, we're living in a world of discursive contagion, and that it can be about the vaccine, that can be about mental health. And mental health as a discourse, as you're probably acutely aware, is one that both values people's experience, honors it, and at the same time completely separates it from the context of its production. And what are we as systemic practitioners? How are we as systemic practitioners going to help join dots? How do we do that? How do we interface with the rest of the world around mental health? I'm sure a lot of you are really preoccupied with these questions. They're not just mine, they are just ones I'm articulating right now. But I think of the way, and what's happening as a result of this discursive contagion around mental health discourses is that the waiting list is growing and growing, and in some clinics, completely unmanageable. And in fact, a waiting list is a promise. It's a promise of something. It's a promise of we'll get to you and we'll offer you something. Can't say what, but we'll do our best. And we know, and it's a difficult one. We know that a lot of people get to an appointment. They want a diagnosis, for example. They want something and it's not what they're not satisfied. Not because there's anything wrong with them, their expectations, but because there's some kind of mismatch between the narrative of the for example, child and adolescent mental health clinic, adult services, and what can actually be offered. So what you might be offered is an assessment for something where there's going to be another gap, or a diagnosis to which there are no responses. You offer the diagnosis and people think, now maybe I'll get some help. Maybe I'll get some advice, maybe, but maybe not. Often not. That's tricky. I wonder whether we should even have waiting lists. It really raises questions about whether we can just how to work, how to resource, whether to resource even, and what to address as the, let's say, causes of people's difficulties. There's also some other interesting changes going on because people are more informed. There's much more talk about, for example, mental health and a sense of entitlement to health services for a range of reasons. And so that's interesting. People are becoming much more consumers of health services, of mental health services. They know more, expect more. We need to be differently accountable. That's very interesting. Maybe people are less scared of being labelled as difficult patients. Probably not, but I'd like to think so. There's also, of course, the shift to online therapy. And while I was doing this presentation, I was thinking, I don't know. Do we even need to talk about a clinic? Is a clinic perhaps now a virtual thing? Because a lot of people are going to want to make choices not to go into a building, not to leave town early, take, whatever it is. They will want to be in a more comfortable place than whatever the clinic can provide. Maybe they want to be in a clinic because it can provide a different kind of privacy or social element, or who knows. But it's something to think about, and who's going to make those decisions about what kind of services to offer. The worker fatigue thing is a real worry. I know so many people who've had to take time off work because of stress, feeling overwhelmed, feeling just exhausted, often by a lot of admin, by a lot of pressure to just keep seeing people, to have to switch between services, cover for other people off sick. I mean, it's something that we could talk about more, I guess, in an ongoing way. But ultimately, I think the clinic creates a story of us and them. That kind of culture, it's very hard to undo, however nice and welcoming one is. And this is I just want to flick this in, because don't worry about it too much, but this, some of you might recognize, is a fusion of two diagrams that drawn the coordinated management of meaning, levels of context. The first one is from Roseanne Leppington, and the other is from John Burnham. So they're a fusion. But why I wanted to show this is to just point out what for me is so special about systemic practice. And it's this: we're not just interested in what you do at a level of method and how to evidence it and what you do within it as techniques and what that produces. We're interested in what's behind all of that, how we are influenced by our ideology, culture, family, religion, political culture, different professional cultures, paradigms, but ultimately our most fundamental and deeply held beliefs about how the world works, what we take for granted as common sense, are the theoretical propositions falling out of all that ideological stuff. So our assumptions factored in here show the contextual force that our choice of methods is influenced by our ideology. And the ethical element of what we do is allow ourselves to be changed implicatively at every level of context, potentially. That is very special to systemic social constructionist thinking. It's a gift from CMM, a gift from these wonderful theorists, practitioners. But I wanted to put this up to show with the red arrows what is special about our ethical approach. We're not just interested in going on courses to learn methods. We want to and need to interrogate and identify the ideological context that ideas have been produced in. And this is another moment in time where we have to do all of that again, especially and consciously right now, and think, how are the practices, the ways of talking, the ways of welcoming, the use of eye contact, all manner of things, the language, everything. How is what we do influenced by our most fundamental ideological beliefs, attachments, and so on? And how do they then influence what we consider to be useful ideas that inform our theories? How do our theories come about? Where do they come from? Remember, theory wasn't just there. Somebody made it up. People have made these things up, often out of a lot of hard work. But they made them up in response to very particular situations and particular contexts at very particular points in time, out of cultural context, temporal contexts. In the context of all manner of power relations, they may have been fight backs, they may have been acts of resistance, they may have been despite lots of other constraints. So we can honor how they came about, but we need to relook. We need to have these talks. So I wanted to share that with you. Oh, and just talk a little bit more about the Kensington Consultation Centre and CMM, Coordinated Management of Meaning. It's a very useful tool, CMM. For those of you not familiar with it, there are a lot of great free materials on the Pierce Associates website, and no doubt on the CMM Institute website, with which I'm just not as familiar. Human Systems was the journal for the Kensington Consultation Centre and for the wider systemic community internationally. It embraced CMM very early on. I'm showing you this particular issue, which was a special issue on the coordinated management of meaning and how it was being used. But CMM shows, if you think back to that diagram I just showed, it shows you ideology at work. It shows you that no theory is decontextualized or innocent. It came from somewhere and is put to use in certain ways. And it showed how change can take place or not. And KCC was kind of like CMM in action, because it was very reflexive. It was very rule creating as opposed to rule bound. And when I look and think about human systems, for which we must absolutely thank Professor Peter Stratton and Dr. Helga Hanks for their long-standing, unbelievable, candle-burning, round-the-clock devotion and rigor over the years, and daring as well, lots of daring. They made human systems happen. It arose out of KCC and the Leeds Family Therapy and Research Centre, but Peter and Helga were human systems. But what happened within KCC in relation to human systems is that everybody doing the courses wrote. They wrote not just their assignments, but they turned their dissertations into publications. And if not everybody, everybody was encouraged to. It was part of the culture. It's kind of what you did. And there was a sense of it being a bit like an experimental playing field. You just couldn't wait for the next issue. Something new was happening. There was always something new happening. It was as though there was a sense of inventing as we went along, whether in terms of the building, therapy, assignments, or dissertations. Of course, KCC was bold. It didn't want to be prescribed to by any outside authority more than it had to be when it achieved university recognition for its programs. So it held its own register for the Systemic College of the UKCP. It resisted standardization. It also had its biases, of course. It was inevitable. Some people were hurt or ideas constrained, but there was a sense of making things together, making new things. It was a community. The whole place was like a learning zone. And the birth of the professional doctorate in systemic practice that KCC gave rise to, that eventually was transferred into the University of Bedfordshire, that I have had the privilege of leading, has tried to replicate this kind of culture. Of course, we should also mention the summer schools. I want to just mention some sites of resistance that don't just come from the systemic stable. I was thinking back to, well, I wasn't ever part of this, but I was thinking about the history of one of the first counselling courses in London, run by Francesca Inskip and Bridget Proctor at the South West London College, as it was then. I think that might now be part of Lewisham College, I'm not sure. But they did something different. They asked people, the trainees, what they needed to learn. They made up a curriculum with people. What do you need to learn in order to become a counsellor? And I wonder now about the kind of prescribed teaching. People who know me will know I'm absolutely an advocate for getting rid of the blue book and freeing ourselves in order to create more contemporary responsive ways of doing therapy and therapy training. So there was something very daring and innovative about that particular program that Francesca and Bridget set up. Sue Holland was a psychodynamic therapist who worked on the White City estate, got a flat on the White City estate, held counselling sessions there, set up groups in the early 80s in ways that made therapy counselling accessible for people. Brent Family Service Unit in Harlesden went through, I was working in the London Borough of Brent at the time in the early 1980s. But I was working for the local authority in a long-term children and families team. And Brent Family Service Unit was, at the time, we were doing some joint family therapy training together. Brent brought in David Wilmot, and he did lots of training with us, first in the playful work of Jay Haley. We trained in that, and then we trained with in the more conductor of the session kind of ideas of Minution, and then very early Milan ideas. But the team in Brent Family Service Unit changed hugely from this a shift where they were moving more towards formal family therapy, well, and of the sort I've just described, all white workers. And then they employed a single black worker. And within, for a range of reasons, the team changed entirely. And they became a black team, an entirely black team with one white worker. And they changed their practices entirely to work alongside the community, to recognize strengths in the community, to facilitate community projects, and to deliver community-based counselling in a variety of buildings, including securing a house on an estate and introducing all manner of activities in that building that were more alongside, more relevant. There was less distinction between worker and local residents. Some of the workers were local residents. It was a very different kind of positioning and linguistic culture and, well, culture on a range of levels. It was a reclaiming and a re-theorizing. And then there were the Teams conferences across Europe, across the world, and it was very much an era of experimentation in the 70s and early 80s. I've mentioned here just a few organizations. For those of you who haven't, and I don't think many of you will have done, Charlotte Burke has just finished making a documentary about the origins, the history of systemic practice in the Tavistock and Portman Clinic. Well, it would have been the Tavistock Clinic at the time when it all started. And it's going to be a fantastic documentary. Do look out for it. It's being launched within the Tavi soon. And it's taken a long time to put together, and reminds us of how the clinics were playing fields, not playing in the sense of not caring, but playing in the sense of really experimenting and feeling that ideas and time to consider, time to discuss with each other was important. The Fifth Province work at Mater Misericordiae in Dublin, the Marlborough Clinic, Prudence Skinner, of course, the Milan team, the Family Institute Cardiff, AFT, KCC. The pink practice I mentioned as a site of resistance came about because it might be hard for people to either believe or remember or whatever, that it wasn't that long ago that lesbian, gay, queer people were simply not allowed into a lot of the training institutes in the UK. I can't speak for elsewhere, mainly the psychoanalytic ones. But even the systemic trainings were still in the early days, drawing on a lot of normative developmental theory about what counted as healthy, normal relationships, lifestyles, and all the rest of it.
Gail, just to let you know, you've got 10 minutes.
Thank you. So the pink practice grew up in order to, from within and alongside the queer communities, in order to make sure that we had ways of talking and doing and theorizing that were coherent with our well-being. We're living in a panmorphic crisis. There's so many things going on. This is a term I developed. I find it kind of satisfying to use this term. It's a kind of cluster bomb of so many things going on. Climate crisis, of facing up to the fact that Black lives have not been mattering, and that people have been systematically destroyed, the culture's destroyed over time, invisibilized, disappeared, overlooked, what's happening. That the neurodiverse communities are speaking up, speaking out, making a case for being removed from mental health discourses. Trans people and gender fluid people are helping us all rethink what counts as choice, necessary, questioning basics about gender. The same with ability and disability. These are all concepts that we need to reconsider. The world's in a complete spin in terms of climate. Well, it's kind of off kilter. We're melting, we're on fire. There's so many urgent needs in meta matters and materialities. And there are tussles, of course, as we know, between epistemologies of control, between fake and truth. And well, I just want to read something quickly from the International Congress of Qualitative Inquiry. This is a historical present that cries out for emancipatory visions, for visions that inspire transformative inquiries, for inquiries that can provide the moral compass to move people to struggle and resist oppression. What does a transformative paradigm mean under such circumstances? And simultaneously, how do we confront the human-made pandemics of inequality, poverty, suffering, racism, climate change, violence, oppression, and injustice? How do we continue to face these matters in the contemporary moment? There is no turning away. Now we're going to skip this, much as it looks really interesting, but you can have the slide another time. So it's a good time for us to change, and the disruption of our thinking and our daily practice from, for example, the Black Lives Matter movement is something to immerse ourselves in for how long? Maybe the rest of our lives. This is not something one does a weekend course in. We need to rethink gender, age, ability, and how people access resources, what resources count as, how they're made. These are very short moments we're living through in the COVID-19 pandemic. We need to remember the human time frame is incredibly short compared to that of a mountain, which is why we sometimes mistake mountains for inanimate and other materials we call inanimate, but are in fact living, just not in our anthropocentric time frame. But I think two of the key questions for us in the systemic community are how we can decolonize systemic training programs, of course our workplaces too, and decolonize ourselves actually, but how we can also depathologize ourselves, trainees, colleagues, clinics, practices, because decolonization and depathologization are closely linked. And that's something that's worthy of further exploration. I hope people will take it up. This is a kind of quick, strange loop from CMM about how we might consider rupturing cultural homeostasis and some of the binds we find ourselves in. So, for example, on the left-hand side, this is what systemic therapy training looks like. And then there's some kind of disruption, whatever sort. And as a result of that, changes are made to what systemic practice or systemic training looks like. That comes from a multi-ethical imperative. We make changes. But then we run into some problem. Oh, this isn't what systemic therapy looks like. Oh, we won't get validated because we're stepping outside of the blue book or whatever it might be. And then there's another form of disruption. And we make more changes to what systemic therapy or training can look like, which comes from more of a monoethical, restorative position. And then we kind of, in a sense, are back to the beginning. The dotted arrow on the left shows what it's like to be not in a strange loop, but more in a kind of moving, fluid set of practices where we say we need to make changes. Systemic therapy, systemic training looks like whatever's happening, and it'll change some more depending on the feedback we get. And there's this lovely quote from Donna Haraway who says, it matters what thoughts think thoughts. It matters what knowledges know knowledges. And it matters what relations relate relations. It matters what worlds worlds. It matters what stories tell stories. I want to propose that we need to move away from the romantic question by Gregory Bates and the one where he asks, what pattern connects the crab to the lobster and the orchid to the primrose and all four of them to me and me to you and all six of us to the amoeba in one direction and dated language, offensive language, and the backward schizophrenic in another. Okay. And maybe we need to kind of contemporize that for a number of reasons, both to take into account the world we're in and the kind of shifts in understanding people, more respectful approaches to difficulties over time, less othering. So, for example, how can we connect the one-way screen to the PlayStation and the microplastic in placentas with sex trafficking and all four of them to me, and the Black Lives Matter movement to the Xiaomi smartphone, and me to, not you, and me to someone born on the same day as me in another less well-off country, and all eight of us to economic structures and those experiencing something called mental health problems. There's lots of new things going on, new sites of resistance, new independent practices springing up around the place. And I want to say something about this because I think independent practice, or what was formerly known as private practice, has had bad press by people often working in state services as sort of some money-grabbing capitalist enterprise. I think people who haven't experienced the permissions of setting up something where you're in control of the pricing, of the ways of working, need to maybe rethink what the benefits are of having independent practices. People are very generous in independent practice, in my experience. You can make up all the rules and feel less scrutinized. So there's a lot, and work in culturally specific ways that are right for you, where there's less performing roles in of the clinic. Just mentioning some of these things, the ecosystemic return, the systemic autism network, these are political movements, Murmuration's Journal of Transformative Systemic Practice, but also there's something new happening next year, and that's the Lenticular Futures launch. Watch this space. It's a practice and research institute for the systemic relational arts with qualifying programs and hopefully a shifting disruptive CPD program. Very quickly, Karen, have I got 60 seconds?
You have 60 seconds only.
I reckon some of you have been thinking about sheds in the last year. So if we're rethinking the clinic, or rather where our work can happen, meaningful spaces. Oh, welcome to the family therapy suite. Might be too popular. We've needed a lot of outdoor spaces. Oh, and this is one of my colleagues, Chiara Santon, works a lot of time outside. This is one of her outdoor working spaces now in a local park. Why can't a therapy space look look like a place of privilege? What messages would it give people? What can neurodiverse people tell us about lighting, about positioning? What makes us comfortable in our home environment? And who are we asking about these things when we're thinking about interior design or building design for our spaces of work? I don't know why we sit up to do therapy. Maybe it's because my own early analysis was lying down on the couch. That suits me. I like lying down. But there is something also about this performing looking. That is an interesting question. What can our training spaces look like that reflect the dialogical relationality that we're expected to do in our work, to try and sound as normal as possible? Bachelard, in his 1958 book, The Poetics of Space, said, if I were asked to name the chief benefit of a house, I should say the house shelters daydreaming. The house protects the dreamer. The house allows one to dream in peace. Now, lots of people will feel that that isn't true of their house, that they simply don't have that privilege or advantage. But it does make me think, why I put it in is, makes me think, what are we offering people in a therapeutic space? And then what other kinds of spaces can we create even within rooms, sacred spaces, peace parks, tent talks, med sheds? And, well, this is a big one, two big ones. How do we communicate with young people, with anyone? Our one-way screens are so dated technologically. And by the way, has anyone checked that the recording kits can't be hacked? So what's your dream space? How might you get it? If you change the activities, you change the story, if you change the location, I don't know. What do you want? What do people want? But also, what do you feel allowed to do? And what can you do about the voices you hear that say, oh, you can't do that? So Lenticular Futures is going to create a different kind of environment that embraces somehow online and in-person spaces, not simply inspired by and inspiring of diverse communities, but led by those members of those communities. It's going to take inspiration from Afrofuturism, transmateriality, Black feminism, critical thinking, critical race studies, Indigenous knowing, queer theory, critical autism theory, radical disability theory. We need to think more about the politics of sites for treatment. We need to rethink again and again the concept of problem, but situated in wider systems, wider socio-political contexts. We need to rework the concept of talking therapy so that it includes other activities like the arts, like poetry and place and documentary, whatever's relevant to people in this day and age, so that we can reinvent what counts as meaningful communication.
Gail, I'm going to have to interrupt you.
That's
and
okay.
That feels painful because
no, that's okay.
Transfixed.
I finished. That's it.
It's so exciting what you're talking about. My whole body is resonating, and I think you're daring us to dare, and it's a real challenge. And I'm going away with that word. There can be no turning away.
Yeah.
There is no other option. We have to rise to this challenge. Gail, so profound, so beautiful, but also so challenging. Thank you so much.
Thank you very much.
And we
want to sorry, go on, Karen.
We want to invite everybody back to the discussion after a 15-minute break, where we will be really pleased to hear your responses and your connections to what Gail has generously given us. So thank you.